Hey guys, welcome back to Illness Scripts Pencast. Today we're going to create an illness script for Rocky Mountain Spotted Fever. Rocky Mountain Spotted Fever is a tick-borne illness that's quite prevalent in certain parts of the United States, especially the eastern United States. The type of tick carrier actually varies based on the location, with the American deer tick being the most common tick in the eastern U.S. Thus, predisposing factors would include geography as well as a known tick exposure. The likelihood of Rocky Mountain Spotted Fever infection increases with the duration of the tick exposure. Interestingly, this disease is actually more common in men than women, and in children ages 5 to 9. I think these demographics, though, are more reflective of tick exposure risk rather than actual true susceptibility to the Rocky Mountain Spotted Fever. Patients will endorse a history of very nonspecific findings early on, which makes having a high suspicion for Rocky Mountain Spotted Fever crucial to making this diagnosis in a timely fashion. These nonspecific findings most commonly include fever, malaise, myalgias, and occasionally even nausea and vomiting. Sometimes as much as even a few days later, a maculopapular or occasionally petechial rash will occur. This rash starts peripherally on the palms and on the soles, but later may spread centrally. So this is the so-called centripetal rash. Compare this rash to the distribution that you would expect to see in like a viral exanthem, which may also be on the differential, which usually starts centrally but will spread outward, thus centrifugal. This classic triad associated with Rocky Mountain Spotted Fever is fever, headache, and rash. But keep in mind, these may not be present in all patients, and in fact, some may never even develop this classic rash, making the diagnosis extremely difficult. Exam findings would really be limited to the aforementioned rash, which is notably usually blanching on exam. Other findings could include hepatosplenomegaly. Despite the headache and fever, meningeal signs would be rare, so this should make you think about other diagnoses on your differential. Let's talk about some of these key distracting diagnoses for Rocky Mountain Spotted Fever. Of course, other tick-borne illnesses must be considered in the differential, but so much so that they may even be a co-infection with Rocky Mountain Spotted Fever. Fortunately, most of these are also treated with doxycycline, which makes making this distinction nothing more than an academic exercise. The most important alternative diagnosis that you absolutely cannot miss is meningococcemia. These patients will also have fever and headache, but usually with a much more convincing meningeal exam, but not always. The rash seen in meningococcemia is diffuse and classically rapidly spreading. Though the rash is often petechial or purpuric, I believe that unlike Rocky Mountain Spotted Fever, the rash often does not blanch. These patients rapidly deteriorate, and this disease is often fatal even with appropriate treatment. So going back to Rocky Mountain Spotted Fever, some of the lab findings that we would expect are really just nonspecific and would include thrombocytopenia and elevated transaminases. We see this pattern a lot in most tick-borne illnesses. Hyponatremia may also be seen. Serology is often used to make the diagnosis, but treatment should never be delayed for results, as titers may not rise until days after the onset of symptoms, and the test may take some time to come back anyway. As meningitis is often appropriately on the differential, CSF studies may also be obtained and are often normal, though the findings, as usual, can be quite variable. They never really should be markedly abnormal as you would expect, though, in bacterial meningitis. Thus, an ideal illness script for Rocky Mountain Spotted Fever could be a 9-year-old boy, noted onset of fever, malaise, and headache 3 days ago following a camping trip in the woods, now with a blanching maculopapular rash which started on the palms and soles, but now is also located on the trunk, as well as some splenomegaly on exam, with thrombocytopenia and elevated ALT on labs. Thanks again for watching. Please remember to like this video and subscribe to my channel to get future videos. Leave a comment with future topics you want me to see covered that can help you either on the boards or on the wards. Until next time.